Well, hello and welcome everyone. I am Kate Warren, Executive Vice President and Executive Editor at Devex, and I'm thrilled to be here with you and to be hosting this event in partnership with Pivotal Ventures. Thank you for joining us from all corners of the globe for a conversation that feels both very overdue and urgently needed. So let me set the scene for what we are talking about today. Half the world's population is still navigating health systems that weren't built with them in mind. And I'll let you take a guess on which half of that population it is. But women spend more of their lives in poor health than men. Too many face preventable risks during pregnancy and childbirth, and conditions that disproportionately affect women from autoimmune diseases to mental health challenges remain chronically underfunded and under-researched. And then the pressures of conflict, climate change, fragile health systems, the inequities really just deepen. So that's the reality, but it's also not the whole story. Across the world, innovators are developing bold, community-grounded solutions that prove what's possible when women's health is actually prioritized. And we're seeing breakthroughs in research, reimagined care models, and approaches that could really scale if they had the right investment and support they deserve. So, in response to this longstanding gap, Pivotal and Lever for Change launched the Action for Women's Health Initiative, a 250 million global call that's part of a broader 1 billion commitment to expanding women's power and influence. You may have already heard from some of these incredible innovators featured in our Devex podcast these past few weeks. And today we're going to hear from even more alongside other leaders in global health who are really helping to push this work forward. And so that's really what we're here today to spotlight what's working, to talk frankly about what needs to change, and to explore how philanthropy, policy, and cross-sector collaboration can truly close the women's health gap. To kick us off and to really help really set the scene for today, I'd love to introduce Haven Lay, who's the Chief Strategy Officer at Pivotal Ventures. Haven, welcome.
Hey, thanks so much, Kate. And a huge thanks to the entire DevX team for making this conversation happen. It's an incredibly important one that we care deeply about. Um, the sun is about an hour from being up here in Seattle. So good morning to those of you who are in the West Coast of the United States, good afternoon, and good evening if you're elsewhere across the globe. I am truly happy to be here with all of you. Women's health is a major priority for us here at Pivotal, and we are so excited to be part of this event. As Kate mentioned, I left the Gates Foundation to go help start Pivotal with Melinda French Gates about a decade ago. And at the Gates Foundation, I was a program officer focused on making sure that our grants were actively addressing gender disparities. And I worked on smallholder agriculture. In fact, I first got to know Melinda the best and fairly well on a trip to Ethiopia. We were on a listening tour of women farmers, and we wanted to understand what types of barriers they were coming up against and accessing inputs like fertilizer and irrigation, and how we could help them become more successful in their farming practices. And even though we were there to talk about farming, overwhelmingly, women kept circling back to health. Many of them were too tired to tend to their crops effectively because they were anemic, and others had to care for ill family members, making work in the fields tough. And others knew and just talked to us out of nowhere about how they weren't able to access contraceptives and they weren't physically ready to have more kids. Whatever the issue, the point they were making time and time again on that incredible trip was, and remember, we were there to talk about economic livelihoods. It was painfully obvious. It's hard to do your job. It's hard to feed your family. It's hard to just live your life when you're struggling with you or your family's ill health. It becomes the most important thing. And I imagine lots of women and men watching today can relate to that feeling. Because it doesn't matter where you are in the world. If you live in a woman's body, there's a very good chance you could spend, as Kate mentioned, nearly a decade of your life living in poor health. You are more likely to suffer from anxiety and depression. You are more likely to be diagnosed with an autoimmune disease. And we're certainly more likely to be misdiagnosed after an event like a heart attack. And yet, less than 1% of funding for health research goes to women's health issues outside of cancer. And this is an incredible, major funding gap. It's also a major opportunity. There are so many ideas, solutions, leaders, and organizations out there. Many of you are on this call today that can dramatically turn the tide on women's health if they got the funding, attention, and sustained support that they need. And it's this opportunity is why Pivotal partnered with Liver for Change to launch that $250 million global open call to support organizations working on women's physical and, importantly, mental health. We announced the awardees a couple of weeks ago. Many of you were on the call, and we couldn't be more inspired by the work that you're doing to help women around the world get the care that they need. It's also why we partnered with Welcome Leap, which brings together a broad group of researchers and scientists from different sectors and industries to invest in women's health research and produce bold innovations years and maybe even decades sooner than traditional R&D approaches. And it's certainly why we're going to continue to have conversations like this one, thanks to Devex. If we combine our efforts and focus our attention on women's health, we can replace those sobering health disparities that women face with a different future reality, one in which health is no longer a barrier that holds us back, but is rather the engine that propels women and, frankly, all of us forward. So thank you to everyone who's active in this space, who's advocating and working on solutions to women's health access, services, and research. Your work means the world to us, and we're getting much, much closer to that vision thanks to your efforts. All right, good morning again, and Kate, back to you.
Thank you so much, Ivan. I love that, changing health from a barrier to an engine. So we have a really great lineup of speakers today that we'll be hearing from. They'll be talking to just that. But first, I would like to introduce Dr. Avni Amin, who's the unit head for rights, equality, and well-being at WHO's Department of Sexual and Reproductive Health and Research, someone who's really been at the forefront advancing women's rights and well-being across the life course. So Dr. Amin, thank you so much for being here.
Thank you so much. It's a pleasure to be here.
So, when we look at health inequities for women, a very obvious one first comes to mind is pregnancy and childbirth. And we talked about how that can play a really big role in some of these inequities. And WHO data shows that over 700 women die every day from preventable causes related to pregnancy and childbirth. And so from your vantage point, what are the most critical system level barriers that you think we really need to tackle to accelerate progress in this area?
Thanks, Kate. So I think most of us know about the three delays that contribute to maternal mortality and morbidity, right? So the first one is women making that choice and decisions around health seeking and also around bodily autonomy when they want to become pregnant. The second one is getting to the health facilities in a timely way, especially if there's an emergency and they don't have transport to get there. And then the third is when they arrive at the health facility, there's a whole host of health system level barriers that prevent quality of care to be provided to that woman. I think the first two really speak to the need to address what we call are the gendered, social, economic, environmental determinants of women's health. And the third one, which is what you're asking me about, is systems level barriers. So if you look at what are some of the predominant causes of maternal mortality, the biggest one is postpartum hemorrhage, sepsis, hypertensive disorders, and obstructed labor. And of course, one of the things we know is that we have to focus and prioritize addressing these big proximate causes of maternal mortality. But the second is to make sure that there is quality of care, and not just quality of care from an institutional perspective in terms of having commodities, in terms of having equipment, having safe and dignified space for women to deliver, but a trained health workforce. And we know that that's a challenge in many health systems where health workforce, midwives are in short supply, as are nurses, as are physicians. But I think the third one that I want to flag is what is important from women's perspective. And what women often tell you from a quality of care perspective is they want respectful treatment. They want not to be disrespected and abused during labor. They want health workers, nurses, health professionals to speak to them with respect, to respect their self-determination. So from a WHO standpoint, one of the things we are doing around systems level barriers is, of course, prioritizing, providing innovations and guidelines around postpartum hemorrhage. We just came out with the consolidated postpartum hemorrhage guidelines, also guidelines on managing diabetes during pregnancy, which we know has risk factors for acquiring diabetes later on in life. And then there's a whole set of consolidated guidelines around positive pregnancy experience during antenatal, intrapartum, and postpartum care. And I just wanted to highlight that one of the system level barriers from women's perspective that we highlight is the importance of respectful care, training health professionals to provide that, allowing women to have the emotional support during labor by recommending that women are allowed a birth companion of choice, and that they get postpartum follow-up in a way that is not just about the child, but also about meeting their own needs for health and well-being. So I'll stop here to answer these, but I think these are, for me, the big things that I think the health systems can do.
Yeah, really treating them as a person, not just a patient. And when we talk about women's health, it also is much broader than maternal health. And as Haven said earlier, includes mental health, other chronic and autoimmune conditions, aging. It's the full arc of a woman's life. How can global and national health systems really evolve to serve women across their entire life course, not just thinking about during pregnancy or crisis moments?
So I think you said the magic word, which is a life course approach, right? So I sit in a unit which is called Rights and Equality Across the Life Course. And here we really emphasize the importance of looking at women's health across the life course, from birth to childhood to adolescence and the reproductive years. And then, of course, menopause being another big transition into healthy aging. And we need to pay attention to women's health across all of these different stages. The second, I think, important thing is to understand that, of course, women's bodies, their physiologies evolve across the life course, but so do those determinants. And those determinants interact with what happens to their bodies in a way. And I think you've heard of the famous saying, the body keeps score. So a lot of what happens to women in the older ages is a cumulative impact of traumas, both physical as well as mental and emotional traumas that they've suffered. So I think we need to address both the risk factors and the determinants, as well as the evolving health needs. I think the third thing that is important is paying attention to what we call are the critical transition periods. So, of course, early childhood is one critical period, but adolescence, puberty, and I speak particularly with a lot of passion about what happens to adolescent girls when they hit puberty. We know that a teenage pregnancy can set girls into a health and well-being trajectory in a very negative way, unless you support them in many, many ways. And on the other hand, addressing some of the adolescent girls' health needs early on can actually set them onto a positive health trajectory across the life course. The other critical moment we already spoke about is pregnancy, big changes in body and social and emotional life that are important. And the third one, which I think is increasingly getting a lot of attention, is menopause, because that's the window to transition into healthy aging. And we need to do a lot more around that. The last bit I wanted to talk about is not just to look at women's health in terms of the life course and these determinants, but to look at other issues that women disproportionately are affected. And I think you talked about mental health. Well, one of the biggest risk factors for women's mental health is violence against women. And we just put out last week violence against women prevalence estimates, which show that 1 in 3 women experience intimate partner violence or non-partner sexual violence. And this rate hasn't changed much in 2 decades. And we know that this has enormous consequences on their mental health. We also know that violence has impacts now increasingly on non-communicable diseases. So really paying attention to these kind of risk factors is an important way of comprehensively addressing women's health across the life course. And then,
Yeah,
of course, you mentioned the autoimmune diseases, you mentioned lower back pain, Alzheimer's and dementia. Most women I mean, the majority of the cases are in women. And again, I think all of these conditions need a lot more attention.
Yeah, absolutely. And we're going to be speaking with some innovators later today, and there is a lot of innovation booming across health and women's health, but really getting that integrated into public systems can be a challenge. So, kind of briefly, how are you thinking about WHO and local partners being able to bridge that gap between all this great innovation and the policy that can really help scale it?
So I think innovation is a exciting. I mean, there's a lot of exciting opportunities to put out there different products that can help women across the life course. I think, but we again go back to doing some systems level thinking. And here I do want to talk a little bit about the work that we want to do around making sure that ministries of health in particular have the epidemiological data across the life course. In 2009, we had published a Women and Health report that looked at women's health across the life course. So one of the things I think we would want to do is to update that data. I think 15 years later, the world has changed. The epidemiology of women's health has changed. And that will allow ministries of health to make much more precise uh, interventions around, what are the big priorities, including risk factors that they need to address in their region and in different age groups. So I think that's one priority. And in a way, it's a bit of a low hanging fruit because we would just have to update that based on the global burden of disease. The second one, which is a little bit more ambitious, is really paying attention to the what I call the unaddressed and under-addressed areas of women's health. Menopause is a clear one where believe it or not, the world does not have guidelines to address menopause. So that would be another important priority that we would want to take on board. But not just, I think we need to do a lot more around menstrual health, menstrual bleeding, endometriosis, PCOD. These are conditions that, debilitate women, prevent them from going into the workplace. For girls, they lead to school dropouts. So again, addressing these. The third one, which I would say is a much more ambitious one, but I think is really tackling the limited research that has been done on women's health across the life course. And here I would say not only do we need to provide guidance to the R&D community around inclusion of women, including pregnant women in clinical trials, but to really foster research, and I mean longitudinal research, multi-country research in low and middle income countries, focusing on some of the neglected areas. And I would definitely say for me, the three ones that we would pick up is around adolescent girls, because that's an entry point to look at how women's girls' lives evolve over trajectories in low and middle income countries. The second one is around looking at violence and mental health in childhood, in adolescence, and during pregnancy. We know postpartum pregnancy is a particularly vulnerable period for women experiencing violence. And then menopause is the third area where we would want this kind of research to be done. Believe it or not, there are very few longitudinal cohort studies tracking women and understanding what's happening to them across the life course. One of them is in the US, which you all know well, but the others in Australia, Canada, and low and middle income countries just unfortunately don't have that. And then finally, I think what we need to do, and I hope we can do this as part of the research we would want to do, is really listen to women. Women talking about their own lives, their lived experiences, and the kind of questions we want to ask should be informed by women's priorities and not just what the industry wants or what health policymakers want. And the last one, I promise, is around making sure, I think ironically, even as the health systems are among the most feminized workforce, it is also one of the most patriarchal institutions, right? So you've got 70% of the workforce being women, but the leadership of the health systems is largely men, and we need to change that. And we need to make sure that the health workforce is being more gender sensitive to women's needs, women's autonomy, their self-determination, and providing that respectful quality of care.
Well, Dr. Amin, thank you so much. As somebody who is going through the perimenopause phase myself and finding it very hard to navigate, I really love hearing that this is something you all are working on. But thank you so much for sharing your insights with us
Sure.
today.
Sure.
Before we move into our next panel discussion, we are going to hear briefly from Melinda French Gates, whose vision helped spark the Action for Women's Health initiative. So we'll play the video now.
We live in a world that has never made women's health a priority. As a result, across the globe, women spend 25% more of their lives in poor health than men do. If we want to see women's health finally get the attention and investment it deserves, we need to start doing things differently. That's why I partnered with Lever for Change to launch a $250 million open call for organizations working to improve women's mental and physical health around the world. In the 25 years I've worked on women's health, I've seen firsthand that there are amazing organizations out there that are already doing the work. But most have never had the funding they need to truly maximize their impact. After combing through applications from all over the world, we've selected more than 80 awardees, an incredibly diverse group of organizations working across 6 continents to make sure women have the care they need at every stage of their lives. At a moment when governments around the world are slashing funding for women's health, the role these organizations are playing in women's lives could not be more important. I'm honored to be standing behind them and the life-saving, life-changing work they do for the women who depend on them. Because when women are healthier, the world is too.
Well, thank you. And speaking of amazing orgs doing amazing work, I'm thrilled to bring in 3 leaders whose organizations are really reshaping women's health from the ground up. So I'd love to introduce to you all Dila Perera, who's the Executive Director for Open Arms Perinatal Services, Dr. Junice Demeterio Melgar, who's Executive Director for the Likhaan Center for Women's Health, Inc., and Fatia Kiange, who's the Executive Director for the Center for Health, Human Rights, and Development. So thank you all so much for being here today. So I am going to start with you, Dila. And we talked a little bit earlier about the challenges in childbirth and the care that women receive. And you're working in Washington State and working with birthing people in a community-based support. Can you talk a little bit about how outcomes can shift when you shift a birthing people community-centered model that's a culturally matched support? And what kind of changes you think can happen when you take this model? Maybe talk us a little bit about your approach and some of the benefits that you're seeing from it.
I'm happy to, and thank you everyone, and we're honored to be part of Action for Women's Health and to be supported in this way. So greetings from Washington State, where the sun is not yet risen. We are one of the first organizations on the West Coast of the United States to provide culturally responsive, community-based birth support during pregnancy, birth, and lactation. And over nearly 30 years, we have served over 4,000 families, mostly people of color in the United States, which, as you know, is not a leader in the global north in terms of health outcomes during pregnancy, birth, and early parenting, especially for families of color in the United States. And one of the things that we have found is that by providing someone who is of and from the same community, who can point someone to halal foods, who can talk about traditions during pregnancy, birth, and early postpartum that are healthy and helpful and nurture connections, things that are innate in each culture and community, we can drastically reduce health disparities and outcomes. So for Open Arms, our preterm birth rate is half of what it is for the United States and half of what it is for Washington State. And our differences are the most significant in communities of color, especially for African American, Indigenous, and foreign-born families. And that includes preterm birth, low birth weight, and unnecessary interventions during pregnancy, such as cesareans or other interventions that affect the baby as well. So we have really found that by taking that step of giving someone a companion, as Dr. Amin described it, during birth, who really can speak to the person, create trust, create support, create a bridge during one of the most critical moments of someone's lives. You really can change the trajectory of that pregnancy, of that birth, and of that early parenting journey.
Thanks so much, Dila. And also just a flag for those tuning in. We are hoping to get to some audience Q&A, and I see some of you have already added some questions. Feel free to add them in the Q&A box, and we will try to get to some of those as time allows. So Dr. Junice, I want to bring you in, and you work closely with women and girls in underserved urban and rural settings where sexual and reproductive health access can be quite limited. What are some of the barriers you're seeing today, and how is your rights-based grassroots model really trying to influence both the policy and practice?
Well, just to be brief, I will talk about two barriers. No? One is very structural. This is the lack of a gender and rights framing of health and development. Development first, so you don't even have gender equality as a target of government. There is no gender analysis at the highest level. So you expect that at the healthcare level, there is blindness too. So even when there is reproductive health, so we had a reproductive health law passed in 2012 after 10 years, long 10 years, arduous struggle. But even the reproductive health law is not well implemented. So you have contraceptives that are very limited to, the cheapest contraceptives. So the long-acting contraceptives that women in the Philippines want, they cannot get that in an affordable manner. So even when you talk about women's health, it's basically reproductive health. But even contraception tends to hew towards population control. So it's really not thoroughgoing rights-based, right? And the other big barrier is the continuing opposition of, just to be mild about it, conservative religious groups continuing, whether they're Catholic, Protestant, or Muslim. And they used to oppose family planning, but they were defeated there. But they're opposing comprehensive sexuality education, they're opposing adolescent services without parental consent, LGBTQ, etc. So those are the big barriers. And what we are trying to do actually is popularize the rights approach in practice. So at the community, you socialize. We have organizing that socializes older women, but also young women about their rights, about their entitlements, so that they can have a voice, they have confidence to raise their voices in the family, community, and in policy settings. But there's also at the national level, we continue to work on policy changes, executive policies with the Department of Health, with the Department of Education, with PhilHealth, social health insurance, which is so critical to women, especially with the rhetoric of universal health care. And then, of course, we work also with laws, like divorce law. The only country without divorce is the Philippines. And then, of course, for us, supporting women in the informal sector. Some of the poorest women without rights are women in the informal sector. So just briefly, those are the problems, and that is what we interpret to be rights-based.
Yeah, so Fatia, I think it's perfect to bring you in. So Dr. Junice talked about rights and law, and you're doing some interesting work on leveraging litigation to help with women's health. Can you talk a little bit about this approach and what you're doing?
Thank you so much, Kate and colleagues. I'm glad to be here. So our organization, which is the Center for Health, Human Rights and Development, CHEHAT, here in Uganda, is actually advancing women's rights and the rights of other vulnerable communities using the law. We use the law to advance health rights of our communities, and that means that we actually that means that we use it to make the states, the governments, accountable to respecting, protecting, and fulfilling human rights, and with a particular focus on health rights and specifically women and girls' rights. So what we do is we actually engage the courts of law to enable the states to execute those obligations of respecting, protecting, and fulfilling the health rights of people, and the women being on top of those that we serve, and girls. So some of our landmark court judgments in areas such as maternal and child health, sexuality education, mental health, sexual gender-based violence, detaining women in health facilities because they are not able to pay for services, have actually brought us systemic changes. So that's the approach we are using, and maybe a bit later I'll talk about how successful we have been. One of our particular cases, which is a famous case, a constitutional court judgment on maternal health, it's called Petition 16. If one went onto the website, they can easily get it. It was decided in 2020 after 9 years of litigation. And we believe that it has brought significant change in terms of budget going towards maternal health, in terms of skilling healthcare workers, in terms of equipping health facilities, in terms of surveillance and response to maternal health challenges. And we've seen that over that period, our maternal mortality has dropped by 44%. And we think that this court judgment has had an input into that, in addition to other interventions from other partners.
Yeah, I love that. And, it's not something that we often talk about or cover in our global health work, is how important the legal system is to that. So I'd love to just go around to each of you and, hear from you. Right now is a little broadly a challenging funding environment for global health, and particularly focused on women. And, I'd love to hear how you think this initiative offering multi-year flexible funding, how does that change what's possible for your work? And what would you like other funders to learn from this model, or what organizations like yours really need to be able to scale the amazing impact that you have? So Dila, I'll start with you.
As much as it has been a difficult time and continues to be difficult in different ways, we are all have dedicated our lives to something that is so intrinsically human, that will happen no matter what. Babies will be born, people will grow up, people will make decisions about who to love, who to partner with, how to interact on a sexual human level. And so the work continues at the grassroots, at the highest levels. What having this multi-year funding means is it creates the ability and the safety to innovate, to try new things, to push for longer term changes in addition to providing services in our case. And it also is just an excellent reminder of the fact that organizations like ours exist. It gives us a platform to show what we're capable of doing, and to show that there are many other organizations like mine throughout the United States in very small communities. Some of them may not even be incorporated into nonprofits yet, who are doing the work and will continue to do the work. And having access to flexible funding, multi-year funding, can often be the thing that launches them into sustainability and to being a trusted, grounded resource in their community for years to come.
Love that. And Dr. Junice.
Yeah, for us, that has been branded. We are stereotyped as a radical group, that is for a feminist radical group, always in the streets protesting. But I think this is an affirmation that radical groups like us actually are doing good. So we're not just rhetoric, we're doing good on the ground. So this funding will actually allow us to standardize our programs. We are working in 8 areas funded by different funders with different goals, different metrics, etc. So standardization is very important, making sure that we have the technology, we have the management information system for all those programs is very critical before we scale up, before we propagate. Like we were thinking of distilling the lessons into a training center for activists, who are community organizers, who are health providers also, who are advocates. Also to replicate maybe and co-create models of care for women that have been for a long time marginalized, like women with disability, women in prison, like women deprived of liberty, indigenous women, even Moro women. So there is a large of scope actually to make sure that the women that are hardest to reach are reached by we're Catholic, so I will call this a blessing, this very big blessing, which is also a big responsibility for us.
That's great. And Fatia? Oh, I think you're muted.
Thank you so much, Kate. This multi-year flexible support is definitely going to enable us to expand and deepen our work on strategic litigation, on legal aid, and also generally access to justice by women and girls who face injustices, social injustices, inequalities, and health rights violations, both within the health system, but also through other sectors that impact women's health. How we are going to do, what our experience is that many donors do not like supporting litigation work, and they don't like supporting legal aid work because cases take many years and most donors are supporting short-term projects. So in fact, in all our programming, those are the least funded areas. And so this particular multi-year flexible funding is coming to help us continue to deepen and expand that work. Even in terms of numbers. So we have a legal aid program, for example, and most of our clients are girls who face sexual violations. And in fact, Avni talked about the delays to access health services. For us, we actually see delays for girls and women to access justice because they don't have $3 to access a health facility, to carry out the medical examination, to access police and report the case. And then later, when we come in to help them have justice, we are unable to get that because of what happened earlier on in terms of transport and other factors. Many of them fear the justice system. They don't know where to start. They don't even understand it. So we come in to address all that and walk the journey with them. And we are delighted by this support because we are going to support many more women and girls in such situations of injustices. For other donors, I think what we would like to see, I think a long-term flexible support is important because barriers and persistent challenges to women's health are actually due to society's path-breaking, gender inequalities, in poverty, social and cultural norms that cannot be changed by very short-term projects with small funding. So I think for other donors, if we are going to get where we want to be with women's health, we need to invest in flexible long-term funding, but also invest in these institutions to be sustainable and more resilient, including the support for their human resources, including the support for their systems so that they can stand the test of time.
Yeah, big systems change takes time. So I'm sure that this funding approach is helpful in being able to invest that time it takes. We're talking a lot about some of the barriers and challenges, but I also want to spotlight, what is possible and, some of the really great things your organizations are doing. And so I'd love to hear from each of you, maybe just like a story or an anecdote of what is possible when we are able to get some of these systems right, and what that can help showcase for the broader health community as to, where we can make gains. And Dila, I will start with you. And yeah, any kind of story from your work that you think shows the power of your approach.
So as part of our model, we match people as much as possible by culture and community with someone who is of and from the same community. And what we have seen over many years is that we are not working with only just one person in a family. We're often working in later years, sometimes with sisters and cousins and aunties. And that some of the people that we have provided with birth and lactation support have come back to us and have been so inspired by the support that they received that they want to be trained to provide that support to others. So we have members of our staff, members of the team of doulas that we work with, who began as clients and now are providers themselves and are filling really unique niches in the United States in terms of language skills and cultural expertise. And then they often go on to continue to work in the healthcare system. Some of them will become nurses, some of them become midwives, some of them become lactation consultants, and they continue to pay it forward. And one of the things that we all know is that when we have providers that look like us, we often can associate that with more trust and better care. And so the fact that it's a multi-generational long-term shift is something that I'm incredibly proud of.
I love that. And obviously we need more healthcare workers. So that's a real win-win. Dr. Junice?
In our 30 years, no? So let me give just a background of the three-pronged approach, no? So we do organizing of women and young women in the community, basically for self-reliance and to be courageous, no? in changing things. But the other part is clinical services that are run by mid-level providers that are women-centered. And the last one is policy advocacy. And my stories actually revolve around community health workers, very poor from the communities where we work. Some of them migrants, from very poor migrants, never finished high school, no, and yet they are very intelligent. So it's the first time that I've really come across what you probably would call diamonds in the rough, right? And they're working as house helps until we actually discovered them and asked them to help run the community-based health programs. So they have been trained as health workers. They have also been trained as organizers. So they are the ones that actually propagate information to a much wider audience, like 50,000 a year. But in their lives also, their lives have changed. So some of these community health workers started as maybe docile wives who never went out of their homes, who were very worried every time we had a meeting that would last beyond 5 p.m. because they have to rush home and cook for the family. You know? So they started like that. And with socialization, with modeling, with interaction with other women who had the same problem, they have risen to be leaders. So they've risen to be leaders of women's organizations. And actually our policymakers, I remember the Secretary of Health, two of them, former Secretaries of Health, actually requesting these community health leaders to speak about the reproductive health bill and the future of reproductive health law, because they thought they were the ones who could convey the message that would resonate about why such a measure was needed. So you have these women talking in public, talking in Congress, talking in the Senate, and they have manifested even in their lives. No? So you see their husbands helping with the housework. That's frowned upon in the Philippines, but the spouses are helping out. And when you see the second generation, their daughters are more independent-minded, are really averse to marrying, no? So they're cohabiting. They have really full sex lives, but they're not bound much like their parents were before. So this change for our organization, it took 30 years, but we see this actually happening, that their lives change, and then they can also work better for the family, for their families, but also for their community. Those are the stories.
Yeah, love that. Fatia, I know you started telling one story about a successful case, but yeah, any other stories you think can really help illustrate the power of your model? Oh, sorry, you're muted. Oh, Fatia, I think you're muted.
I think I'll build on this case in a different way, that many institutions fear to use the law and to go to court about obligations of governments. But what we have seen is that it's possible to go to court, at the same time continue to collaborate and work well with government. Initially, our organization was seen to be that organization that goes to court. But when court directed, for instance, for Parliament to increase the budget for maternal health, the Ministry of Health recognized that they were the beneficiaries, they benefited from that. Quite often they put priorities in their budget that are not funded, but court judgments are enabling government to actually comply with court decisions. So I think for me that's quite an important one, and that litigation combined with legal empowerment of communities. One of those approaches we use also, extending our litigation, is legal empowerment for communities to know their rights and also demand for their rights, but also ask for accountability from duty bearers. But we also empower the duty bearers, especially at subnational level, to understand the obligations to communities, so that when communities are asking, they are responding appropriately. So I think for me, those are some of the lessons I can bring. We also have another case where the rights of young women living with HIV/AIDS were really violated because there is an annual beauty pageant where they really also participate, and somebody came up and really powered that down and stigmatized them, that they should not be doing that because they're living with HIV/AIDS. And we actually went to court. This time it was the court of the Equal Opportunities Commission in the country, which is responsible for equity, gender and equity assessments and ensuring compliance with government institutions. And again, we got a positive court judgment, and that sets a precedent for institutions and individuals who want to continue causing stigma and discrimination for people living with HIV/AIDS. So I think that I can go on and on, but we definitely have stories of these approaches that seem to be impossible, but are making a difference in our country, and they are replicable in other settings. They are replicable in Africa and other parts of the world.
Yeah, that's so great about speaking with all of you. There are different parts of the world and all the amazing things you're doing, and I'm sure being able to learn from each other. I know we have some questions that have been coming in from our audience, and Dr. Amin, I know you're still with us, and there are a couple of questions that maybe with you in mind. So happy to bring you in to tackle some of them. But one I'd like to start with is from Lindsay. And what advice would you give to NGOs that are already demonstrating strong impact for women and girls, but haven't yet been fortunate enough to secure investments like this? What do you think organizations can do to better position themselves for sustainable funding, long-term partnership? Would any of you have any advice to share with somebody else who's looking to get similar kind of funding? Dila?
I can just say quickly that measure your impact as in whatever ways you can. And that can seem like a huge luxury when you're so busy doing the work. And sometimes that's just paper forms that you file after visits with families until you can access funds for a database. But track your outcomes, track your stories, track your data. And when you have a funder who's willing to help you create and analyze your data, seize that opportunity, because telling your story is one of the most powerful things that you can do.
Great advice. Dr. Amin?
Yeah, I mean, I think one of the things that we have to get a bit bolder about is thinking about innovations that can be sustained through scaling up in partnership with government platforms. And I know it's not always easy to work with government, but if we are thinking about sustainability and we're thinking about scale, it is important for NGOs to build that from the beginning in mind, that whatever we do, is it going to be scalable and sustainable beyond sort of the cycles of funding that often NGOs are subjected to, and can the government, because in the end, yes, women's health organizations are at the front line of innovations, but the governments have to take accountability and responsibility for women's health, and we have to hold them accountable for what they should be doing for half their citizens.
Yeah, I think that leads into another question we have here from James on the role of health insurance. Coverage for women seems like a powerful tool for improving maternal health. From a rights-based perspective, is there an example from anyone in the panel on lessons learned in terms of holding governments accountable and providing access to affordable health insurance? Is this something that anyone? Yeah, go ahead, Dr. Junice.
Yeah, this is probably what is our partial success, no? Because we've been able to engage. Insurance is something that poor women need, no? So in the Philippines, poor women would be enrolled by government, so government would pay for the services. So we have that kind of program that we have actually been encouraging women, whether they're dependents of their spouses or they're independent women, to enroll in PhilHealth and to be able to access. So that's what we are engaging with PhilHealth for, to make sure that their enrollment processes are friendly to women who don't have computers, who do not understand, the interlinkages of the government, the national government, etc. So that's what we do. They call it navigating the very complicated Philippine health insurance system, but it's very important. But also pushing for insurance benefits for women. So we were able to advocate for contraceptive services. So PhilHealth before would only have like IUD, intrauterine device, which is long-term, and nothing else. So in insurance now, you have a short-acting. It can cover like a full range of family planning methods. It already covers maternal care, including complicated deliveries. It covers cancer, breast cancer, cervical cancer. So all of this, we're trying to push. It doesn't cover yet violence against women. It doesn't cover yet like screening tests for cervical cancer prevention. But this is a package of services that we would like to push PhilHealth, like a women's health package. And we were successful with them before in 2015. So I think this is what Dr. Avni was talking about, that we need to engage with, some parts of government that is working, to select and to work, because we were able to cover, like in some clinics 40%, in some clinics 60% of our expenses, from PhilHealth. So this is, I think it's a good story for women that can have the opportunity of engaging in social health insurance.
Yeah, great.
Yeah.
And yeah, go ahead, Dr. Avni.
No, I just wanted to build on what Junice was saying and acknowledging that, one of the things we can do from a health systems perspective is really advocate for a basic package of care to be part of what we are calling universal health coverage. So, defining those packages, making sure that governments understand that without, for example, maternal health, sexual and reproductive health services, we cannot have universal health coverage. And so that has to be part of the essential package of services. It has to be financed by the public sector systems, hopefully through not just government budgetary allocations, but also through health insurance, national health insurance schemes where they exist.
Thank you. And yeah, in our last couple of minutes, Fatia, I'd love to see if you have any thoughts on these questions, or just generally another one from Jennifer on how any of you can talk about how you coordinate with the public or private sectors to really scale your approaches, and any advice you have there.
Yeah, I think for health insurance, we are far behind. We don't yet have a national health insurance scheme, but as an advocacy and litigation and research organization, we are definitely advocating for national health insurance because it's part of the priorities for the new national development plan for the country. So we are pushing that we see women's health incorporated fully, including sexual and reproductive health and rights. And I definitely think Dr. Junice's example is a good one and a good learning for our side.
Great. Well, thank you all so much. I know limited time to talk about such a big issue, but really great to hear about all the exciting work you're doing and some practical ideas and approaches for continue to tackle the many barriers that are out there. So again, thank you. I know everyone's joining from very different time zones, very different weather. So thank you so much. But before we close out our program, I would love to introduce Kristen J. Molyneaux, who's the president and co-founder of Lever for Change, for some reflections on today's conversation. So Kristen, over to you.
Thank you so much, Kate. It's such a pleasure to gather with everybody here today. And thank you so much for all of our speakers and panelists. And coming away from today's conversations, I think two things are really clear to me. The first is that despite making up half the world's population, we know that women's health is chronically underfunded and overlooked. Dr. Amin spoke to the systems level barriers that women are facing when it comes to their health across the spectrum of their lives. And the second thing that is abundantly clear to me is that there are solutions out there. Today, we heard from Dila and the team at Open Arms, who are doing critical work to provide community-based, culturally matched support for birthing people in Washington State. We heard from Junice and the team at Likhaan, who take a rights-based approach to shifting women and girls' access to sexual and reproductive health. And Fatia and the team at Shaherd, who are driving accountability in women's health through strategic litigation and community mobilization. And I think what is incredible about this is that these are just three of the more than 80 Action for Women's Health awardees who are leading real impact for women across geographies, life stages, and identities. When we first launched this open call with Pivotal, we set out to surface bold and innovative solutions that could transform the way that women's health is prioritized around the world. The response that we received has exceeded all the expectations, and particularly underscored the urgency and creativity that is driving solutions for women's health worldwide. From grassroots initiatives to global collaborations, these organizations demonstrate that transformative ideas are not only possible, but they are already in motion. The Action for Women's Health awardees do not just envision a world in which women's health is treated as essential to the health of our communities, but they are charting the path to its future. And through Action for Women's Health and their broader $1 billion commitment to expand women's power globally, Pivotal is demonstrating the power of investing in women's health. So while today is the culmination of the Action for Women's Health open call, it is just the beginning of a whole new chapter. To see real lasting change for women's health, we will need everyone to continue to coordinate investments. We need everyone to collaborate around advocacy, and we need to nurture innovation as well as many more things in order to continue to promote women's health worldwide. We each have a role to play in shaping a healthier future for women everywhere. And we invite you to join us in this movement, to continue investing in these organizations, and to help accelerate the change that women deserve. Thank you so much for everybody for joining us. This has been an incredible morning and a way to start the day for us here in Chicago, and probably for many of you to end your day elsewhere in the world. But we thank you all for coming, and I'll turn it back over to the Devex team for any final comments. Thank you so much, Kate.
Yeah, thank you so much, Kristen. And I'm struck by often these conversations are led by women, and I think that's so important to have women's experiences at the center of these conversations. But of course, investing in women's health is also investing in everyone's health. And so I, really invite our full audience to to explore and learn more about the great innovations that you are doing, and we put some links in the comments here so you can learn more about the great work that's being done. But in closing, thank you so much to Pivotal Ventures and Love for Change for helping us showcase these amazing innovations. Thank you to our speakers, and thank you for tuning in and joining in. These conversations and the solutions behind them really help move the women's agenda forward. And so we'll hope you'll stay engaged and share these insights. We also encourage you to explore more in this series, as well as listen to some more of the interviews of some of these innovators in our podcast this week in global development. So if you don't already subscribe, this is my plug to subscribe now. But in the meantime, thank you all so much for joining. And again, thank you to our speakers today.